Hello, good afternoon, and welcome to today's Intensive Services Grand Rounds at the University of California, San Francisco's Department of Psychiatry and Behavioral Sciences. My name is Dominic Tarpey, and I have the honor of introducing our speaker today, Dr. Christopher Bartley. Dr. Bartley's presentation is entitled Clinical and Diagnostic Features of Autoimmune Psychosis. It's been my pleasure to have Dr. Bartley as a cherished colleague for the past several years. Dr. Bartley completed his medical training at Yale, where he also completed a PhD in neurobiology, completed his psychiatry residency and a clinical fellowship in immunopsychiatry here at UCSF. He is a current Hannah H. Gray Fellow of the Howard Hughes Medical Institute. He is a recipient of a research award from the DIDA Blair Research Initiative for the Disorders of the Brain, an initiative launched in 2021 by the Foundation for the Institutes of Health. At UCSF and in the Department of Psychiatry and Behavioral Sciences, Dr. Bartley is on faculty, conducts research, and has a specialty clinical practice in immunopsychiatry. Although I would like to say a lot more about Dr. Bartley, I do want to leave as much time as possible for his presentation. Please feel free to submit questions and comments through the chat. We'll try to get to as many of them towards the end of the hour. And so I will go ahead and turn the virtual podium over to Dr. Bartley. Thank you very much. Thank you, Chris.
Hi, thanks, Dominic. So thank you for the kind introduction. Very honored to be here. And as you heard, I did my training here at UCSF. And I think that a lot of the work that I've been able to do since then could only really have been done at UCSF. So I'm just very grateful for the opportunity to pursue this emerging strain of research. And today, I'm not going to talk so much about the research, but a little bit more about the clinical and diagnostic features of this emerging entity, this emerging clinical entity that we call autoimmune psychosis. And so I don't have any relevant disclosures. And as you probably saw in the email, the learning objectives for today are to understand the clinical definition of autoimmune psychosis, to learn about the clinical features of autoimmune psychosis, and to learn about some of the diagnostic tests for autoimmune psychosis, and then to learn how to diagnose autoimmune psychosis without diagnostic biomarkers. And today, the outline for the talk is going to start off with a bit of background, just a very brief introduction of psychosis, which I'm sure is familiar to everybody in this audience. And then I'll talk a little bit about the history of autoimmune psychosis. This is a hypothesis that's been around for over 80 years now. And we just now have some of the research tools and some of the clinical imaging tools that allow us to try to answer whether or not autoimmune psychosis is really a distinct clinical construct within the broader schizophreniform disorders. And then I'll talk a little bit about the diagnosis of autoimmune psychosis. And really, this is predicated upon the diagnosis of autoimmune encephalitis. And so we're going to start there and talk about autoantibody testing that's used to make a definitive diagnosis of autoimmune psychosis within the context of autoimmune encephalitis. Then we'll move on and talk about the definition and diagnosis of seronegative autoimmune psychosis and introduce a clinical score. And seronegative meaning that there's no clinically validated autoantibody, yet the clinical features are consistent with an autoimmune process. And then we'll move on to the future of diagnostic testing and some open questions. So what is psychosis? I'm sure we all have our own definitions. And so this is an operational definition that I like to use when thinking about psychosis. And psychosis is really a state of disordered information processing. And even though we don't test for this clinically using clinical tests, there are a number of neurophysiologic defects that are associated with the state of psychosis that we do encounter clinically. And so some of these neurophysiological defects that are seen across individuals with a clinical sort of presentation of psychosis include reduced pre-pulse inhibition, impaired sensory gating, blunted mismatch negativity, and efference copy corollary discharge. However, on the clinical level, what we actually encounter are patients, human beings with hallucinations and delusions, disordered speech, and disorganized behavior. And it's very difficult to try to determine what the cause of this psychotic state is on a clinical level. But doing so is important in terms of making sure that we're providing the appropriate therapeutic interventions for patients based upon what we believe to be the underlying etiology. And so the psychotic state can be caused by a number of medical problems, including autoimmunity. But many of you are probably familiar with the emerging story around the complement system and how it may be involved in synaptic pruning, demyelinating disease, endocrinopathies. And you can see that there's a whole host of other causes, including idiopathic and psychiatric causes of psychosis. Over the past 50 years, there's been a lot of work done on the neurocircuitry of psychosis, and there are very real amounts of evidence that support dysfunctions in the NMDA receptor signaling pathway or glutamate signaling pathway, the GABAergic signaling pathway, as well as the dopamine signaling pathway. But once again, we believe that dysfunctions of these circuits can lead to broad circuit dysfunction and drive the behavioral state that we call psychosis, which is really defined by those features that I described before: hallucinations and delusions, disorganized speech, and disorganized behavior. And so today we're going to focus on autoimmunity and how autoimmunity may, in some cases, drive the psychotic state. So for the second part of the talk, I just wanted to introduce you to a bit of the history of autoimmune psychosis. And if you've seen me speak before, you've seen this slide before. And this is a slide from a paper from 1938. And this was a paper by German neuropathologist Hermann Lehmann-Fausches, where he had devised a clinical test to identify patients with brain tumors. And so he would take cerebral spinal fluid from these individuals, and he would mix it with healthy brain tissue, and he would shake that mixture in a tube. And if it formed what he called a flocculate or form a foam or a precipitate, that indicated to him that the CSF was rich in antineural autoantibodies. And he tested this flocculation assay on a number of disease processes. And if you look at the fourth bar there, you see multiple sclerosis. And he found that 24% of individuals with the clinical diagnosis of multiple sclerosis had a positive flocculation assay indicating that there was an antineural antibody. Much to his and everybody else's surprise, when he tested CSF from over 200 individuals with various forms of schizophrenia, he found that about 95% of them tested positive on this flocculation assay. And so he stated it is particularly noteworthy that the individual special forms of schizophrenia, no matter how different they are clinically, behave in the same manner serologically. And so this was a brief but a leading hypothesis in Germany for a while. However, it fell out of favor as it became known that Lehmann-Fausches wasn't blinded to the diagnosis of the patients when performing this test, that it was subjectively interpreted, and many individuals had a hard time replicating these results. If we step back a little bit to the turn of the 20th century, I wanted to introduce the actual discovery of the antibody itself, and it was discovered by Paul Ehrlich, who hypothesized that in response to the body's exposure to a toxin, that it would produce side chains on cells, and we now think of these as antibodies, that would recognize these toxins in a key and lock type manner. And when asked whether or not these antibodies might ever react with the body itself, Dr. Ehrlich said it would be dysetiologic in the highest degree if under these circumstances, self-poisons of the parenchyma, these autotoxins were formed. And he really thought that autoimmunity was not possible. It's quite ironic that just a couple of decades later that Ernst Witebsky, actually an acolyte and a trainee of Paul Ehrlich, was able to induce antineural antibodies in a paradigm that he called experimental allergic encephalomyelitis. And here I'm showing this paradigm with mice, but he actually originally did this with rabbits, where he took healthy brain tissue from healthy rabbits and made an emulsification and injected it peripherally into other healthy rabbits. And then upon autopsy was able to find histologic evidence of lymphocyte infiltration into the nervous system. So as we march forward through time, many of you will be familiar with the dopamine hypothesis, that that was really sort of an emerging explanatory model for schizophrenia that emerged out of a few clinical observations that reserpine and chlorpromazine were able to attenuate psychotic symptoms in some individuals, and these molecules were known to attenuate dopamine signaling, and also that amphetamines, which were emerging in the 1960s as a popular street drug, were able to reproduce many of the positive symptoms of psychosis or schizophrenia. If we jump forward another 40 years, the glutamate hypothesis emerged, and this is a graph from a seminal paper from Javet and Zukin from their publication in 1991 in the American Journal of Psychiatry, where they hypothesized that glutamate signaling through the NMDA receptor was a core feature of the underlying neurophysiologic deficit in individuals with schizophrenia. And this was in part in response to an observation that PCP, which is an NMDA receptor antagonist, was able to recapitulate not just the positive symptoms of schizophrenia as methamphetamine can do, but also the negative symptoms of schizophrenia. And so they thought it was a better model. And this graph here is showing an interoceptive drug discrimination assay where they trained mice to change their behavior in response to being exposed to PCP. And what they found was that the accuracy of the behavioral response to these different agents was dependent upon their degree of NMDA receptor blockade. If we jump forward a little bit further into 2001, Betty Diamond, a rheumatologist at Rockefeller, found that some patients with lupus and neuropsychiatric symptoms of lupus have antibodies to double-stranded DNA that cross-react with the NMDA receptor, double-stranded DNA have antibodies that cross-react to the NMDA receptor. And so she stated in this paper in 2001 that some antibodies to NMDA function as agonists, and hypothesized that some may also function as receptor antagonists like PCP and mediate lupus psychosis. So just 6 years later, Joseph Daumel published the seminal paper that many of you are probably familiar with, and this was the discovery of and description of NMDA receptor encephalitis in 12 women with ovarian teratomas who presented with acute onset psychosis. And about half of those women were initially admitted to psychiatric hospitals because their presentations were indistinguishable from an acute brief psychotic episode. And he stated in this paper that these results emphasize the idea that autoimmunity can affect behavior. However, the frequency of this disorder is unknown. And so the discovery was that these anti-NMDA receptor antibodies, in contrast to the lupus antibodies, did indeed function as NMDA receptor antagonists and downregulate NMDA receptor signaling in a way similar to PCP. So if you look at the clinical sort of picture of NMDA receptor encephalitis, many of the early features look very similar to the onset of schizophrenia, and then it evolves into a more neurologic picture. Oftentimes it's preceded by a viral prodrome, and then after about 1 to 2 weeks, there's an onset of psychiatric symptoms, delusions, hallucinations, mania, agitation, disorganized speech, oftentimes catatonia and disrupted sleep as well. As the illness progresses, neurologic symptoms often overlay on top of these psychiatric symptoms, including seizures and autonomic instability. And these patients will typically then be triaged to neurology, where they'll undergo diagnostic lumbar puncture and diagnostic MRI, as well as antibody testing these days. Although when it was initially described, autoantibody testing for NMDA receptor encephalitis did not exist. And so here you see that there's a very rapid progression between the onset of symptoms and the instantiation of a sort of stable psychotic state. And if you contrast this to the time course of transition from attenuated psychosis to stable psychosis in the idiopathic psychiatric population, you see that it's a much more protracted time course, and that the median time to transition is probably somewhere around 9 months for most of these individuals. And so although the initial presentations may look similar, the progression is much faster in NMDA receptor encephalitis. And this is something that we see in autoimmune psychosis writ large, compared to the more idiopathic psychiatric psychotic populations. So after the discovery of NMDA receptor encephalitis, which was really just a landmark in neurology and subsequently in psychiatry, because it was really the first time that an antibody targeting a neuronal surface protein had been identified that was sufficient to induce such a dramatic behavioral change in the patients. A number of groups got together to come up with diagnostic criteria, revised diagnostic criteria for limbic encephalitis within the context of autoimmune encephalitis. And at this time, there was really no sort of distinction between autoimmune psychosis and autoimmune encephalitis. And really, autoimmune psychosis was just thought to be sort of psychosis in the context of autoimmune encephalitis. And so the early diagnostic criteria stated that a diagnosis of definite autoimmune encephalitis / autoimmune psychosis can be made if known neuronal surface autoantibodies are present in the serum or CSF, and there is a response to immunotherapies. And they went on to state that a diagnosis of probable autoimmune psychosis can be made if known neuronal surface autoantibodies are present, or there are other neuronal antibody markers of an immune process, such as Gad65 autoantibodies, and at least one clinical supportive feature, which are not described here, and there is a response to immunotherapies. And then finally, they said if there's no neuronal surface autoantibodies, a diagnosis of possible autoimmune psychosis can still be made if other neuronal antibody markers of an immune process are present, or at least there's clinical supportive evidence, or there is a response to immunotherapies. And so here I'm showing you the timeline of the discovery of autoantibodies targeting intracellular targets or intracellular proteins on the top half of this timeline, or self-surface antigens on the bottom part of this timeline. And you can see that NMDA receptor autoantibodies are indicated in the middle on the bottom. And since then, there have been a number of neuronal surface protein targets that have been identified that are known to be targeted by autoantibodies. And so in yellow are those antigen targets that are highly associated with cancer. And so typically individuals will develop a paraneoplastic neurologic syndrome that targets these antibodies in the context of cancer. And then those antigens that are in the red boxes are those antigens that are associated with psychotic symptoms to some degree or another. And so you can see that recently there's been an explosion in the discovery of novel neural autoantigens that are targeted by autoantibodies. And as a result of this, there are a number of clinically available diagnostic tests. And almost all of these diagnostic tests start with a diagnostic screen. And the screen is called a tissue-based assay. And this tissue-based assay is performed with either rat brain tissue or mouse brain tissue, and sometimes with non-human primate tissue. Although because the non-human primate brain is so much larger, there's a limitation there in that it's hard to test the entire anatomy of the non-human primate brain. Whereas with the rodent brain, you can test for antigens, antibodies to antigens expressed anywhere in the brain. And then rodent proteins are about 85% conserved with human proteins on the amino acid level. And so it's thought that if an antibody binds to rodent brain tissue, it probably binds to human brain tissue as well. And so these tests are offered by Quest Diagnostics, ARUP, as well as Mayo. And we tend to find that the Mayo tests tend to be more sensitive, and that they oftentimes will communicate more information than some of the large testing providers. Nonetheless, what you're seeing here is the immunostaining pattern produced by antibodies that target a number of different neuronal surface proteins. And on the bottom right, you can see a negative control. So this is DAB staining. So anywhere you see dark brown indicates that there's an antibody in the CSF of that patient that's bound to that particular anatomic region in the mouse brain tissue. And what you can see is that there are some antibodies that are highly specific for certain anatomic regions. So if you look in the upper left, you'll see that antibodies in NMDA receptor encephalitis are tropic to the hippocampus, which is that sort of curled structure right in the middle of the brain, and that they aren't terribly immunoreactive to the cerebellum. And if you look to the right, you can see that the cerebellum is relatively non-immunoreactive. If you contrast that with these AMPAR receptor autoantibodies, you see that once again, there is a lot of immunoreactivity in the hippocampus, but there's also immunoreactivity in the cerebellum to the right, as well as the cortex overlying the hippocampus. And so based upon this initial screen, you can get a yes/no answer as to whether or not there is an antineural antibody. But as you can tell, that although there is some variability in the immunostaining patterns, among these different antigens, it's difficult to state with certainty what the target antigen is just based off of the immunostaining pattern alone. And so if this diagnostic tissue screening is positive for an antineural antibody, then the biospecimen will be reflexed to a diagnostic assay, typically a cell-based assay or a line blot. And in the cell-based assay, they will take the antigen of interest, say the NMDA receptor. They will overexpress it in a cell line. These are typically HEC293 T cells, which are human embryonic kidney cells. And then they will immunostain those cells with the patient's own antibodies in their cerebrospinal fluid or in their serum, and counterlabel with an antibody that binds to that antigen, so a commercial antibody to NMDA receptors. And then they will look for anatomic co-localization on a cell-by-cell basis. And you can see that the patient's CSF in green here really nicely overlaps with the expression of the NMDA receptor in red here. And you can see that that co-localization is pretty good by looking for regions of yellow in the inset below in G. In blue, you see nuclei stained, and you can see that there are additional cells here that were not transfected or don't express the NMDA receptor and also are not immunolabeled by the patient's antibody. And so this cell-based assay would be considered a positive diagnosis of NMDA receptor encephalitis in this patient. Now on the right, you can see a line blot, and these line blots were pretty similar to some of the rapid antigen tests that we're all familiar with from COVID. However, rather than looking for antigens, they're looking for antibodies, and they've immobilized proteins at different places along this line blot. And so this works like a similar to a Western blot in which you're looking for antibodies that bind to protein. However, this works by capillary action, and CSF or serum that may harbor the antibody is incubated with this line blot, and then we look for human antibody bound at different positions, and this allows you to detect the presence or absence of antibodies targeting these antigens that are associated with autoimmune encephalitis or autoimmune psychosis. And you can see that one of the advantages of this is that if you look at the third lane here, there are some individuals that have antibodies to more than one antigen, and you can identify them with a single test. So there's been a lot of work into the underlying mechanism of these pathogenic autoantibodies, and some of these mechanisms are shown here. So in the case of the NMDA receptor encephalitis, it's thought that these antibodies will bind to these NMDA receptors, and these antibodies will cross-link them. And you can see that the same antibody here is bound to two different NMDA receptor molecules, and that cross-linking drives an accelerated endocytosis of the NMDA receptor, which causes functional downregulation of NMDA receptor signaling and leads to the psychotic state. And some other autoantibody-mediated disorders or other methods or mechanisms. And so in the case of aquaporin 4 antibody-mediated demyelinating diseases, it's thought that these antibodies bind to aquaporin 4 and then activate the complement system, which then pokes holes in the membrane of the cells. Some of these antibodies are known to bind directly to the active site of their target receptors and cause direct inhibition of these receptors. And then other antibodies are involved in disrupting protein-protein interactions and disassembling macromolecular complexes. So further, there are some cases in which these antibodies bound to their target antigen will then bind to the antibody receptor on phagocytic cells and lead to antibody-mediated cellular toxicity. And then in other cases, cells that express these antibody receptors can endocytose these pathogenic antibodies, giving them access to intracellular proteins, and that these antibodies can bind to these intracellular proteins and cause protein aggregates and cellular dysfunction. There are a number of treatments for autoimmune encephalitis, which is the clinical scenario in which we most commonly see autoimmune psychosis. And what you'll see missing from this slide are antipsychotic medications. And we'll talk a little bit more about antipsychotic medications in a slide or two. But you can see that all of these therapies for autoimmune encephalitis / autoimmune psychosis are involved in modulating the immune system in one way or another. So those were the diagnostic criteria for autoimmune encephalitis, in which psychosis is commonly a clinical feature that existed prior to 2016. But in 2016, an international consortium led by Joseph Daumel, who discovered NMDA Receptor Encephalitis, was formed to come up with revised diagnostic criteria for limbic encephalitis, which includes autoimmune encephalitis and autoimmune psychosis. And this is really motivated by a lack of universal access to antibody testing, as well as antibody testing results, can oftentimes take weeks to obtain. They noted that the absence of autoantibodies does not exclude autoimmune encephalitis or autoimmune psychosis, and that a positive antibody test is not always diagnostic. Finally, if you recall those early criteria, response to immunotherapy was a required criterion in the original criteria, but quite logically, response to immunotherapy is not available at the time of clinical presentation. Finally, some patients might not respond to immunotherapy, or at least initial immunotherapy, even though they have an autoimmune process. And so because of this, they came up with these revised diagnostic criteria, which allows clinicians to make a definitive diagnosis of autoimmune encephalitis, limbic encephalitis, or autoimmune psychosis in the absence of response to immunotherapy or a diagnostic autoantibody. And they stated that diagnosis can be made when all four of the following criteria have been met. First of all, that there's a subacute onset, and that means a progression, a rapid progression to stable illness in less than 3 months. And if you recall, that time course is very different than what we see in the idiopathic psychiatric population. And that the subacute onset typically includes working memory deficits, seizures, or primarily psychiatric symptoms, suggesting involvement of the limbic system. Secondly, the bilateral brain abnormalities on T2 FLAIR MRI are observed that are highly restricted to the medial temporal lobes. Third, that at least one of the following is present, an elevated CSF white blood cell count or pleocytosis. In most labs internationally, the normal range is between 0 and 5 cells per millimeter cubed. And so anything above that is considered to be a CSF pleocytosis or elevated CSF white count, or that there are EEG changes primarily involving the temporal lobes. And finally, that reasonable exclusion of alternative causes have been made. And those alternative causes can include infections, metabolic causes, medication effects, cancer, epilepsy, and there's a list of many other causes that include genetic causes. So based upon this more clinical diagnostic framework for arriving at a definitive diagnosis of autoimmune encephalitis, and recall that at this point, there's really no distinction between autoimmune encephalitis and autoimmune psychosis. But based upon this, a clinical score was developed to try to determine, to try to allow clinicians to quickly and easily diagnose definitive autoimmune encephalitis. And so this is the 8-2 score that was developed by Divyanshu Dubey at the Mayo Clinic. And you can see that there are various points that are awarded for different clinical features. So new onset symptoms is awarded 1 point. You can see that a history of an underlying malignancies is awarded 2 points. Seizures, faciobrachial dystonic seizures, which is a very specific subtype of seizures, is awarded 3 points. And that CSF findings and MRI findings are also included in this clinical score. And so what was found upon applying this score to populations of individuals with suspected autoimmune encephalitis is that a score of 4 or higher is 98% sensitive and 84% specific and suggests possible autoimmune encephalitis, while a score of 7 or higher is 100% sensitive and considered definite autoimmune encephalitis. So I'm not going to talk about all of the features of this clinical score. I just want you to remember that there is a score out there that you can use to quickly assess for whether or not a patient you're seeing may have an autoimmune psychosis or encephalitis driving their symptoms. But I did want to talk about elevated cerebral spinal fluid parameters very briefly. And so in neurology, one of the mainstays of diagnosis is a diagnostic lumbar puncture. Early on, the teaching was that if a patient has autoimmune encephalitis, the CSF profile will be inflammatory. And inflammatory is defined by having an elevated white blood cell count or having evidence of intrathecal antibody synthesis or antibody synthesis within the central nervous system. Since then, groups have gone back and looked at whether or not it's true that all patients with autoimmune encephalitis or autoimmune psychosis really do have altered CSF parameters. And what you can see here is that it really varies based upon the antigenic target or the target of the antibody. And so these are two graphs that look at the proportion of patients with pleocytosis on the left or the cell count in the pleocytosis on the right for various autoantibody mediated neurologic disorders. And you can see that for some disorders like GAD65, autoantibody disease, very few patients present with elevated white blood cell counts in their CSF, whereas for others like GABA-B, over half of the patients do have an elevated white blood cell count. Even for those cases in which over 50% of those patients do have an elevated CSF white blood cell count, there are still patients who have normal white blood cell counts in their CSF. And so this indicates that if you over rely upon identifying an elevated white blood cell count in the cerebral spinal fluid, you may miss treatable causes of autoimmune encephalitis or autoimmune psychosis. Another paraclinical feature that's looked for in the cerebral spinal fluid are what we call oligoclonal bands. And so oligoclonal bands are produced by patient antibody. And the way that this is performed is, if you look at this graph on the left, this is just sort of a graphical depiction of the results of oligoclonal antibody testing. The C stands for cerebral spinal fluid, and the S stands for serum. And this looks for antibody synthesis within the CSF that's not seen within the serum. And there are 5 different patterns that are observed. And you can see that if there are no oligoclonal bands, right, so elevated populations of antibodies in the CSF or the serum, you'll see no bands on the oligoclonal band testing. Then there's type 2, where you see multiple bands in the CSF that are not present in the serum. And so this indicates that there is antibody secretion within the cerebral spinal fluid. And this oftentimes suggests that there's either a CNS infection or that there's a CNS autoimmune process. There's pattern 3, where you see that there are some unique bands in the CSF and some shared bands between the CSF and the serum. And then pattern 4, which is the mirrored pattern, where you see oligoclonal bands in both the CSF and the serum. And this is typically indicative of a systemic inflammatory state or a systemic autoimmune disorder. And so actually the most common CSF abnormality that's seen in patients with neuropsychiatric symptoms and COVID-19 is this mirrored oligoclonal band pattern. And then we'll ignore 5 for a moment, because this gets into sort of the complex molecular biology of antibodies. But you can see here that in some cases, we see that oligoclonal bands, restricted oligoclonal bands or type 2 oligoclonal bands, are present in the majority of patients with a particular autoimmune encephalitis. And if you look to the far right, you see that nearly 75% of individuals with GABA-B receptor encephalitis have restricted oligoclonal bands. But in some other cases, like LGI1, very few patients have restricted oligoclonal bands. And then elevated CSF protein is something else that's looked for in autoimmune encephalitis. And once again, you can see that this varies based upon the antigen. Overall, what you find is that if you're using CSF as a way to diagnose autoimmune encephalitis, depending on the target antigen, there may be a proportion of patients that you miss because their CSF parameters are normal, despite actually having an antineural immune response. So in light of this, an international consensus was formed in psychiatry, not neurology, to come up with guidelines for identifying potential autoimmune psychosis. And I think this really tried to recognize the fact that Oftentimes, psychiatric or mental health practitioners are the first people to encounter individuals with autoimmune encephalitis, but also that there may be individuals with chronic or static schizophreniform disorders who may really have an underlying autoimmune process. And so this clinical construct of autoimmune psychosis has been met with quite a bit of resistance. And so the framework that they initially came up with was a very conservative framework that really tries to help mental health providers identify individuals who have a possible case of autoimmune encephalitis or autoimmune psychosis, and then provides recommendations for how to escalate the workup to see whether or not they have a diagnosable autoimmune psychosis. And so what you can see is that in the possible category, what they require is an abrupt onset of psychotic symptoms. And so this is something that we've seen in each of the diagnostic criteria, that there's an acute or subacute onset of neuropsychiatric symptoms or psychotic symptoms in the case of autoimmune psychosis, and that the patient have at least one of the following: either a tumor, a movement disorder, adverse medication response or neuroleptic malignant syndrome, severe cognitive dysfunction, a decrease in consciousness, unexplained seizures, or autonomic dysfunction, typically indicated by fluctuating blood pressure or fluctuating tachycardia and bradycardia. And so if you see at least one of these clinical features in the context of an abrupt onset psychotic symptom, then that should indicate that this patient should undergo a lumbar puncture and a screening MRI. And so in the probable category, they've included information about CSF findings as well as MRI findings. So in addition to the possible criteria, you see that they require that there be at least one there be at least one of the following: an elevated CSF white blood cell count, or bilateral T2 MRI changes, and at least two of the following: CSF oligoclonal bands or increased IgG index. And I haven't discussed IgG index so much, but it basically is another way to determine whether or not antibodies are being produced in the cerebrospinal fluid or in the CNS, preferentially over the systemic circulation. EEG changes, and a positive serum neural autoantibody. So I showed you before some of the diagnostic screening that's done to look for specific autoantibodies and focus mostly on cerebrospinal fluid, but the same tissue-based assay can be done with serum. However, it's been shown in a number of studies that serum-based testing is oftentimes not as sensitive or as specific as CSF-based testing. So a positive serum antineural autoantibody only lands the patient in the probable category, not the definite category. And then based on this rubric, they also defined definite autoimmune psychosis. And once again, this requires abrupt onset psychotic symptoms and that the patient meet criteria for probable autoimmune psychosis, and that the patient is required to have a classified antineural antibody in their cerebrospinal fluid. However, they went on to extend these criteria, and I think that this has been really helpful. They added these yellow and red flags, and these are sort of additional soft clinical features that can clue you in to the possibility that there may be an autoimmune process going on. And so some of the yellow flags are shown here on the left. And I'll just point you to the bottom one: a significantly elevated antinuclear antibody. And so many people will have an ANA antibody of 1 to 40, but a titer higher than 1 to 160 is relatively unusual. And in my own practice, I use a titer of 1 to 320 to raise my suspicions for an autoimmune process. Antithyroglobulin antibodies or antithyroid peroxidase antibodies can also be indicative of a systemic autoimmune process. And it's been shown that individuals with autoimmune encephalitis and psychosis in the context of autoimmune encephalitis more often have these sort of non-specific autoantibodies targeting other organ systems, indicative of sort of systemic autoimmunity. And then there were these red flags that they identified as well, including infectious prodrome. And if you think back to the time course of NMDA receptor encephalitis, there's a subset of patients whose illness is really driven by the presence of a tumor, an ovarian teratoma, but that really just represents about 35% of patients. And the majority of other patients don't have an identifiable tumor, but oftentimes will have had an infectious prodrome. And it now looks as though at least 20% of these individuals have had a preceding infection with herpes simplex virus. Then you also see under red flags rapid progression, adverse response to medications, catatonia, and short-term memory impairment. I think this is really important. Short-term memory impairment, the hippocampus being part of the limbic system, we oftentimes see profound short-term memory impairment in individuals with limbic encephalitis and autoimmune psychosis. So that sort of more general international consensus, for a framework for autoimmune psychosis is relatively recent, and it's currently being sort of tested and revised. And so there isn't a diagnostic test for autoimmune psychosis separate from autoimmune encephalitis yet. And this does raise some questions, though. Are there more general diagnostic biomarkers of autoimmune psychosis? Might autoimmune psychosis account for some fraction of individuals with chronic schizophreniform disorders? And I think this is a really important question because these patients are potentially treatable and potentially curable, not just treatable and manageable. And then, what is the relationship between infection and autoimmune psychosis? And I'll end just by talking a little bit about COVID-19 because it's presented an opportunity to start to answer that question. So the first question, are there general markers of autoimmune psychosis? And so this is emerging data, but recently neurofilament light, which is a protein that's highly expressed in neuronal axons and detectable in the serum. This is a protein that's been used as an indicator of brain injury across a number of illnesses, including brain trauma, and dementing disorders, as well as multiple sclerosis. And now it's being tested in autoimmune encephalitis. And Joseph Gaumau's group compared the levels in the serum of neurofilament light in patients with NMDA receptor encephalitis and those with schizophrenia, and found that a level greater than 15 picograms per ml was discriminatory between these two groups, and that there were some individuals with the diagnosis of schizophrenia that had elevated neurofilament light levels, and that those individuals did end up having NMDA receptor encephalitis. And separately, Amanda Piquet's group out of Denver has looked at autoimmune encephalitis more broadly and has found that in the acute phase of autoimmune encephalitis or autoimmune psychosis, that circulating neurofilament light levels are dramatically elevated relative to controls. You can see 51 versus 6 there. And then in the chronic phases of autoimmune encephalitis, of which psychosis is a common component, you also see an elevation about 2.5 to 3 times above the control population. So neurofilament light is being used on a research basis to identify patients with active or chronic neural damage, but it's not clinically available yet. But I suspect within the next few years, we'll see a clinical test for neurofilament light. And then separately, FDG PET is being used as a paraclinical marker to help to identify patients with possible and probable autoimmune encephalitis. And in Germany and some other European countries, it's also being used to help diagnose autoimmune psychosis. And they've really started to buy into the concept of autoimmune psychosis as a distinct entity. And a lot of the work in this area is coming out of Germany and some out of the UK as well. But in this study, they looked at 61 individuals with autoimmune encephalitis, 32 who had seropositive or classified antibody positive autoimmune encephalitis, and then a subset of then another handful of individuals with seronegative autoimmune encephalitis. And in contrast to MRI, in which only 40% of individuals had abnormal MRI findings, 82% of these individuals had either hyper or hypometabolism on FDG brain PET. And so this has been replicated since then, and it's emerging as an important diagnostic tool in the evaluation of autoimmune encephalitis, and I suspect will be an important tool in the diagnosis of autoimmune psychosis. Another open question that I posed before is, might autoimmune psychosis account for some fraction of individuals with chronic schizophreniform disorders? And so if you've seen me talk before, you've seen me present this slide where I show an association between systemic autoimmune disorders and individuals with schizophreniform disorders. And on the left here, what I'm showing is basically two population-based studies in genetically distinct populations where they looked for an association between a number of systemic autoimmune disorders and schizophreniform disorders across about 20,000 individuals compared to 300,000 controls. And in green are those systemic autoimmune disorders that were associated with schizophreniform disorders, and in red are those that were not associated with schizophreniform disorders. And then rheumatoid arthritis in blue actually had a negative association. What was really interesting is that many of these results were replicated in a 25 million person meta-analysis. And so just like we see that in autoimmune encephalitis, those patients, there's a subset of those patients that have systemic autoimmune disorders. In the schizophreniform population, we see that there's a subset that also has a systemic autoimmune disorder. And so might this suggest that their psychotic process is actually part and parcel to the overall autoimmune process? This question has also gained a lot of traction because depending on the target antigen, the presentation of the illness, the onset of the illness may be indistinguishable from idiopathic schizophrenia. And so many of you will be familiar with this graph on the left, but this is just showing the incidence of schizophrenia, or the incidence of schizophrenia as a function of age. And you can see that most individuals are clustered between 15 and 30 years of age. If we compare that to NMDA receptor encephalitis, we see that the graph looks almost identical, that most individuals with NMDA receptor encephalitis present between 15 and 30 years of age. And so based on this and a lot of other literature that I have not had time to review, a number of psychiatrists have asked whether or not these classified autoantibodies like NMDA receptor autoantibodies and others may account for a proportion of individuals with chronic schizophreniform disorders. And so this is a busy chart, but I'm just going to draw your eye to the rows that are bolded here. And the upshot of this answer is that whether you look in serum or CSF, classified autoantibodies are extremely rare or quite rare in individuals with garden variety schizophreniform disorders, about 2.5% overall. So might unclassified autoantibodies be present in individuals with idiopathic psychotic disorders? And so before I showed you the diagnostic screen for classified autoantibodies, but the diagnostic screen or the screen for unclassified autoantibodies is the same. This is this tissue-based assay. And so Dominic Endres's group out of Germany took a subset of patients with schizophreniform disorders and red flags as defined by the consensus criteria for autoimmune psychosis, and asked whether or not these individuals had unclassified antibodies in their cerebrospinal fluid, and was able to find that about, where's the CSF there? About 38% of these individuals did have unclassified autoantibodies in their cerebrospinal fluid. So this work has now been extended by the same group. I'll talk about this quickly. Yeah, so in the same study, he looked at those individuals with unclassified autoantibodies and characterized them by their anatomic immunostaining pattern, and that's shown in the left column. He had identified 9 individuals, and so that represented about 1% of individuals in the study. And 6 of these 9 individuals were treated with immunotherapy, and he found that all 6 of these patients improved with immunotherapy, suggesting that patients with schizophreniform disorders and unclassified autoantibodies based on tissue-based staining may actually be immunotherapy responsive. This work has now been extended by Dominic Endres, and he looked at 70 individuals with schizophreniform disorders with red flags and searched for known autoantibodies, and only 2 individuals had known autoantibodies, and then looked for novel autoantibodies using this tissue-based screen, and found that about 20% of individuals with schizophreniform disorders and the red flags that I mentioned before have antineural antibodies. When he looked at the CSF profile, he found that the CSF profile was generally normal. In these patients, only 5% had an elevated white blood cell count, although about 33% did have an elevated protein. It was thought that this was due to a breakdown of the blood-brain barrier and leakage of proteins across the BBB. They did treat 8 of these individuals with immunotherapy, and 7 of these 8 individuals were immunotherapy responsive, really mirroring the results of the previous study. And then finally, what is the relationship between infection and autoimmune psychosis? It's been shown that by a number of population-based studies, but mostly out of Denmark, that serious infection can independently increase the risk of a future diagnosis of autoimmunity, and that serious infection is an additive risk along with systemic autoimmunity for a future diagnosis of schizophrenia. And so here they looked at individuals that had been hospitalized with a severe infection and looked at the incidence rate ratio of a future diagnosis of a schizophreniform disorder in the following 5 years. So more to date, this question has been asked in the COVID-19 population. There's been a lot of anecdotal data to suggest that perhaps neuropsychiatric syndromes occur more frequently following a COVID-19 infection. And in Paul Harrison's group out of the UK was able to demonstrate this empirically. And so this was a really well-designed study in which they looked at over 80 million electronic medical records, and they compared the incidence of onset of new neurological or psychiatric symptoms in COVID-19 patients over a 6-month interval, and compared those patients to individuals with other respiratory tract infections, as well as individuals who had been hospitalized with influenza. And so compared to those other respiratory tract infection populations, individuals with a history of a COVID-19 infection are at increased risk for a future psychotic disorder, mood disorder, or anxiety disorder. In our own work here at UCSF, we have some anecdotal evidence of this, and this was a study that was published in JAMA Neurology just last year, where we worked with our pediatric and neurologic colleagues to try to identify whether there were novel autoantibodies in the CSF of a 16-year-old patient who presented with subacute psychosis. And this was a 16-year-old girl without prior psychiatric care or hospitalization, who presented with agitation, insomnia, and paranoid delusions. Her UTOX was positive for marijuana, and she was placed on risperidone and olanzapine, but was not responsive. She was incidentally diagnosed with COVID-19 at that time, and over 12 days, her agitation, delusions, and paranoia worsened. She was readmitted after actually really calling the police and telling them that her mother was attempting to sell her into sex trafficking. Her neurologic exam was not terribly impressive. She did have bilateral hyperreflexia with 2 beats of clonus on the right. And then there was a non-specific flare finding on her T2 MRI. Her CSF profile was notable for an elevated protein, as well as an elevated IgG index, and normal is 0.6 or below, and her IgG index was 1.0, indicating antibody production in her CSF. However, she was tested for known autoantibodies, and those tests were negative. After 20 days, she was treated, 20 days of her symptoms not remitting to olanzapine or risperidone. She was treated with IVIG and intravenous methylprednisolone, and over about 3 days, her symptoms primarily resolved. However, there was some persistent lability, and she was discharged on valproate. So we did tissue-based staining with her cerebral spinal fluid, and we saw that there was some anti-neural immunoreactivity. And so in green, you're seeing antibodies from her CSF that are bound to rodent brain tissue, and this is the dentate gyrus within the hippocampus. You can see that there are some large red cells that are immunostained, and we used a diagnostic screen or a autoantibody screen called phage display to identify candidate targets, and one of them was this kinesin protein KIF21A. And so we did co-immunostaining. We saw that these immunostaining patterns completely overlapped. We also, using that same phage display approach, identified candidate autoantibodies to a transcription factor called TCF4. And this is a transcription factor that's mutated in neurodevelopmental syndrome called Pitt-Hopkins syndrome. The polymorphisms in TCF4 have been implicated in schizophrenia. So we overexpress this protein in HEC293 T cells, and we immunostain those cells with the CSF shown in green, or for TCF4 shown in red. And when you overlay the two images, you can see that the patient's antibody binds only where TCF4 is overexpressed. And so we really did validate that there were anti-TCF4 antibodies in this patient's CSF. So just to summarize, autoimmune psychosis is most commonly due to autoimmune encephalitis, and that autoimmune encephalitis is a validated clinical entity that's diagnosable on clinical grounds, and introduce you to the APE2 clinical calculator. And then autoimmune psychosis is an emerging diagnostic construct, and red flags should lead to an extended workup. Candidate autoimmune psychosis patients who do not meet criteria for autoimmune encephalitis, but do have red flags, may respond to immunotherapy, as indicated by Dominic Endres' studies. And that early recognition of autoimmune encephalitis and autoimmune psychosis does improve outcomes. Finally, autoimmune psychosis may account for an unknown proportion of idiopathic schizophreniform disorders, and infections can trigger CNS autoimmunity and may be a cause of autoimmune psychosis. And thank you for your time.
Okay, well, thank you very much. We're nearly at the top of the hour. A couple questions came in, and maybe we'll just get to one of them now. Any thoughts on Lyme disease? Question.
Yeah, I mean, so Lyme disease is obviously a real infectious entity. There's a question as to whether or not sort of chronic Lyme disease can lead to prolonged neuropsychiatric symptoms. I think in those patients who have clear evidence of active Lyme in their CNS, you're able to make that causal relationship. I think where it gets controversial is for those patients in whom the Lyme testing is negative, and families or patients are hoping to use a prior Lyme exposure as an explanatory model for their loved ones' psychotic or neurologic presentation. And I think that's more challenging to do.
And then a question, do typical structural MRI orders involve T2 flare, or do you need to ask for it separately?
Yeah, so typically they will involve T2 flare. If you want to be safe, you should just request that the neuroradiologist look for autoimmune encephalitis or inflammatory processes. Would also recommend ordering your MRIs with contrast, which can also pick up on inflammation. And if you write that in the comments when you submit your order for an MRI, they will go ahead and order the right protocols to look for MRI evidence of autoimmune encephalitis and other inflammatory processes.
Okay. One last question. What is the prevalence of autoimmune psychosis in older adults?
Yeah, so the prevalence, it really depends on the antigen that you're looking at. And so overall, the prevalence of autoimmune encephalitis, and we think autoimmune psychosis may be sort of a non-completely overlapping subset of that, is about 5 to 10 per 100,000. And there are some autoantigens that are more common in older adults, the prototypical one being LGI1. And so it's something that we certainly need to think about. Many of these autoimmune encephalitides are associated with cancer, as you saw in that sort of timeline of the discovery of autoantibodies that I showed. And so certainly age is one of the risk factors for developing cancer. And so it's certainly worth looking at in the older population.
Okay, we are at time. Thank you so much, Dr. Bartley, and thank you to everyone. We'll sign off now.
Thank you.